ahead and start the event. Well, I want to thank both of our extraordinary speakers today for taking the time to share their thoughts with us at an extraordinary time. And I really do want to underscore that we really have forces that are converging on this moment that are coming from just about every angle and making the ability to focus on a global health agenda, especially for another country doing work in another country, to orchestrate what's needed to find the resources to put the program on the ground in a distant place. And the largest motor for that type of work has been PEPFAR. And these two are leaders at the senior most level in the PEPFAR animal in looking at a new bureau that the State Department created for really looking at both the PEPFAR agenda, but adding security to that agenda. And Dr. Katz has been identified and brought in as the person who's going to help Ambassador Nkengasong orchestrate that effort. I just want to acknowledge the growing convergence of issues and our appreciation to both of you for being willing to try to unpack some of these problems and what exactly it means to the PEPFAR portfolio and resources as it moves back into the global arena. Everyone here knows Mike Reid. He's currently the Chief Science Officer for PEPFAR in the Bureau of Global Health Security and Diplomacy in the U.S. Department of State. This is the new bureau, and has been here as a center director for many years, and has just recently left home to go to the East Coast, and everybody here sends their regards and misses him. Ingrid Katz is the other speaker that we are wonderful and lucky to have, serves as the Director for Behavioral Sciences at PEPFAR in the Bureau of Global Health Security and Diplomacy in the Department of State. She's also an Associate Professor of Medicine at Harvard Medical School, an Associate Physician at the Brigham and Women's, and former Associate Faculty Director of the Harvard Global Health Institute. Dr. Katz's focus at PEPFAR is to accelerate and sustain country-driven solutions to closing gaps in care for people at risk for living with HIV. She's received her medical degree here from UCSF and her MHS from Hopkins, and she's board certified in internal medicine, and in infectious diseases, and we are really lucky to have her today. So thank you very much. So Dr. Reid, I will turn it to you.
Yeah, thanks, Eric. So it's lovely to be with you all. I can't see you all, but I'm glad to be connected to you virtually, and want to communicate right off the bat how much I miss being part of the IGHS community. What Ingrid and I wanted to do was to review with you some of the science priorities of PEPFAR at this moment. It really speaks to the roles that we're playing, and highlight where there is need for greater inquiry and research, which I think is probably relevant to this audience. But before I do that, I recognize that probably this is a group that includes people who understand a lot about PEPFAR and some who may not be familiar. And so with that in mind, wanted to sort of build off of what Eric already highlighted, which was just the amazing impact that PEPFAR has had over the last 20 years. It's 21 years ago that it was signed into law by George W. Bush, and remains one, if not the single most important global public health intervention ever. It's had incredible impact, which I'll review in a moment, but in no small part because of Eric's leadership during his tenure here in Washington, D.C. Where we are today would not have been conceivable without Eric's leadership. And it's funny, it took me moving across the country and working in PEPFAR to really understand the stature and the vision and the prescience of Eric's leadership in terms of where we are now. We would not be here in terms of the HIV epidemic if it weren't for Eric's leadership whilst he was the ambassador at large and the global AIDS coordinator overseeing PEPFAR. So briefly, before PEPFAR, the life expectancy of people living with HIV in sub-Saharan Africa was short, and people were living curtailed lives because of the devastating impact of AIDS. Moreover, countries that were suffering under a weight of the HIV epidemic experienced profound impacts on their economic productivity. And after PEPFAR, through $110 billion of U.S. government investment, we're able to realize an incredible impact. Over 25 million lives have been saved. There are now more than 20.5 million people on treatment, and through the earmarked orphans and vulnerable children's efforts within the PEPFAR portfolio, we've seen a huge impact on children. More than 5.5 million babies born HIV free, and there's a substantial amount of data showing the profound positive externalities of that HIV investment, both on other disease outcomes, but also on economic productivity. And this is where we're at in terms of the epi curve. You can clearly see the incidence of HIV globally has dropped profoundly over the last 20 years, and particularly in Eastern and Southern Africa, where the lion's share of PEPFAR resources are being targeted, but also in West and Central Africa and Asia and Pacific. And all of this has happened in the context of, albeit substantial, but actually flatlined investments over the last 10 years. And really, I want to draw your attention to the fact that despite a huge investment from the US government, there hasn't been an increase in that investment over the last decade. And so that impact has happened despite an increase in the cost of doing business and inflation, which is all the more remarkable, considering the fact that the absolute amounts of funding have not changed. One of the things I wanted to draw your attention to up front, which I think also speaks to why PEPFAR's impact has been quite so remarkable, is the ability to address HIV outcomes and in the context of also addressing health inequities. These two inserts are a little bit tricky to understand. They're Lorenz curves looking at the impact of PEPFAR in terms of people knowing their HIV status, access to treatment, and virologic suppression, but stratified by urban and rural context, with the idea that a midline plot highlights that actually there is no inequity, whether you look across urban, rural, or rich, poor. The point here being that PEPFAR has had it has been remarkable in seeing dividends even in the most economically disadvantaged settings. Which brings me to the present day. Both Ingrid and I are at PEPFAR under the leadership of Ambassador Kengason, and his strategic plan has focused on these 5 priorities: addressing health equities, sustaining the response, an investment in public health systems and security, transformative partnership, and a commitment to following the science. And our mandate is really on the last of these 5 pillars, with an additional focus on creating an enabling environment that empowers community and leadership, that leans into innovation and leads with data. What does this mean? Well, across the PEPFAR portfolio right now, there is a mix of countries that, in terms of their epidemic response, there are some countries that, despite substantial investment through PEPFAR as well as through domestic resources. We are not at a point yet where we're approaching the 95 targets. For those that you don't know these targets, 95% of people know their HIV status, 95% of those that know their status are on treatment, and 95% of those on treatment are virologically suppressed. So in places like Mozambique, South Africa, Cameroon, Uganda, we're approaching that, but we're not there yet. And then we have a subset of countries that really are at those, or close to those 95, included here in the middle of the table. And then a number of countries that we haven't yet reached because of crises that are ongoing, like Sudan and Ukraine and Haiti. And then another subset of countries where we're working to improve the quality of our data so that we can better describe where they're at in terms of their epidemic. If we didn't continue to have investment from PEPFAR, I think it's fair to say that many of the gains that have been achieved could be quickly eroded, and this is why the advocacy of academics and the role of civil society in arguing for reauthorization of PEPFAR is so critical. Without PEPFAR, it's estimated that there'd be a 400% increase in AIDS-related deaths from 2023 over the next 6 years. And without PEPFAR, it's estimated that there would be a doubling of the number of AIDS orphans over the next 6 years. So all the more reason why these investments remain so critical. However, if we're serious about getting to 95 across the countries that PEPFAR isn't working in, we also need to accelerate our efforts and intensify some of the strategies that we're doing. And doing that requires that we address and overcome some knowledge gaps that potentially are hurdles towards us getting to that goal. And what I would like to do in the next few slides is highlight for you some of those knowledge gaps where scientific inquiry is so important. So one of the knowledge gaps that we need to address is how to better reach adolescents and young adults. You know, even in countries like Botswana, Eswatini, Malawi that have achieved those 395 in the adult population, when we look at the cascade in adolescents and young women, we're still not there yet. And in fact, in many of these countries, young people really don't have the same awareness of HIV risk as their parents who grew up in the midst of the epidemic 10 years ago. So big questions remain about how do we reach this population effectively? How can we use behavioral science? You'll hear from Ingrid in a moment about that to better optimize our interventions for this population. Across many PEPFAR countries, another key priority and another type of knowledge gap that we have to address is successfully reaching key populations, men who have sex with men, professional sex workers, other priority populations with HIV interventions. This is all the more challenging in places like Uganda, where there is a non-permissive environment to deliver services for these priority populations. And so we think there are really important roles for science and research in determining or delivering differentiated strategies for these populations. Another key challenge or knowledge gap relates to interruptions in treatment. In the last quarter, for which we have data from 2023, 450,000 people who were on treatment across PEPFAR programs fell out of care. They stopped taking their medications for one reason or another. It's crucial that we figure out better ways to support people to stay on treatment, particularly given that HIV it requires lifelong treatment. And so there's a lot of interest in strategies that can optimize lifelong care for people living with HIV. Another key demographic that we're focusing our scientific resources on is men. We know that men in general are more likely to be estranged from the healthcare sector. Men between the age of 25 and 40 who are not on treatment are 3 times more likely to spread HIV to others than other demographics. And so reaching men successfully is something that we're most focused on. And Ingrid, is a respected scholar in that space. So she'll speak to that in more detail shortly. Another important knowledge gap relates to how to think about drug resistance. Some of you may have seen recently there was a report from the WHO articulating concern about the increasing burden of dolutegravir resistance in high HIV burden settings. I think at PEPFAR, we would take a slightly different stance from the WHO. When we look at the burden of drug resistance amongst people living with HIV on dolutegravir, we actually feel pretty reassured that the proportion of individuals who are virologically non-suppressed, who have resistance to dolutegravir is actually very small. But given that we don't have access to routine genotyping, determining how to assess risk of dolutegravir resistance among individuals that are non-suppressed on dolutegravir is a perplexing problem that we're wrestling with. Certainly compared to the era of efavirenz, much lower levels of drug resistance, but how do we rapidly detect those that are drug resistant or have drug resistant virus is a key priority for us. So quickly, a few other types of knowledge gaps that we're interested in addressing. One relates to the role of long-acting agents, both for treatment and prevention. I think there's a lot of excitement right now about how can we take long-acting prevention tools like cabotegravir to scale as quickly as possible. And some of you will be aware of a capsid inhibitor, lenacapavir, that which we hope will be available soon. It's predicated on the results of the PURPOSE trial that we hope to hear results from later in 2024. But what is the role of these long-acting agents? How can we deploy them effectively to reach the populations for whom they would be most advantageous? Concomitantly, we're really interested in considering is there a role for long-acting treatment in the countries that PEPFAR is working in. These agents tend to be much more expensive. There are challenges from an operational, from an implementation point of view about determining how they would or where they would fit within the landscape of treatment options that are available. But certainly that's something we're interested in exploring. Some of you on the call are already experts in AI and its role in global health. Here at PEPFAR, we are also very keen to lean into the opportunities that AI might afford us. Certainly, there are lots of applications on the back end to optimize efficiency of our operations. However, thinking about the role of AI in clinical programs to optimize service delivery, to help predict who would best benefit from certain interventions is an area where I think there's a paucity of good data, particularly in the era of large language models. And we're interested in science that can help inform where we might use these tools to optimize clinical outcomes. And finally, I'll end by saying that another key area of interest for us relates to optimizing the management of comorbid diseases for people living with HIV. Across PEPFAR countries, as people are living longer on life-saving antiretroviral treatment, we're seeing an increase in the burden of non-communicable diseases. How and what is the role that PEPFAR should play in optimizing the outcome for those non-communicable diseases amongst people living with HIV, like hypertension, like mental health comorbidities? And how can we leverage those investments to improve primary healthcare systems writ large? So these are all examples. I call them like type 1 knowledge gaps. These are knowledge gaps where I think with sufficient resources and excellent research, we can determine an answer. How do we do that, though, I think is an area where we're perhaps trying to focus our resources differently from previously. And moving forward, there is a deep commitment to trying to answer the science questions that we need to answer within HIV programs rather than standalone clinical trial sites. Wherever possible, can we do program science? Can we actually answer these questions in the program so that they inform our strategic goals? Moreover, can we think about asking questions that help us understand the health system at large? Oftentimes, I think we problematize the end user. If somebody doesn't take their medications, it's because they're non-adherent or because the healthcare worker that treated them was stigmatizing to them. Why is that? Why do we, what is it about the health system that might impact the end user's experience? And can we ask questions that give us those insights? thirdly, we're really interested in asking questions that give us answers about sustainability. In many of the countries that we're working in, there is a commitment to increase country ownership, something I'll speak about a bit later. So how can we generate insights that are not only help us understand the best clinical outcome, but help us understand the best clinical outcome in a way that leads to greater country ownership, that is sustainable, that is cost effective, that is relevant to that clinical setting? And can we ask questions that do a better job of balancing rigor and relevance? I think historically, some of the science that PEPFAR has invested in has been very expensive and taken many years to generate insight. Can we ask questions in a way that affords us answers on a timeline that is relevant to our clinical programs? So that's a short summary of some of the knowledge gaps that we are trying to close and the approach that we're trying to employ to close those knowledge gaps. I'm going to hand over now to Ingrid, who's going to cover some of the behavioral science side of things. So over to you, Ingrid.
Thanks, Mike. I hope people can hear me. It's such a pleasure to be here. I've said this recently. It feels like coming home whenever I get to speak with a UCSF audience. I miss the West Coast dearly. I'm wondering if maybe, Mike, are you running the slides? Or yeah, okay, great. So I wanted to come in, we're having me come in here to talk a little bit about what we're thinking right now around these type 1 gaps. And I think Mike really said it so beautifully. These are things that we have answers to. And the framework that he laid out around empowering country programs with evidence-based knowledge allows us to lean into this. And so I'm just going to do a brief overview of some of the activities we're doing. And I will say that I was brought in literally, I think within a week of Mike, we came in simultaneously. I think we're probably the only 2 people who have a toehold still in academia here right now. And I think there's an intentionality to that. I do think our job in many ways is to bridge these 2 worlds, as Mike has laid out so clearly, between science and evidence-based strategies and the programmatic work that's been done so tremendously well in PEPFAR. And I will say that PEPFAR, having witnessed it from the outside, I mean, it's hard to overstate the magnitude and the impact that PEPFAR has had, not just in HIV, but in global health writ large, in terms of its capacity, in terms of health system strengthening. And so this moment really is a unique one, as Dr. Goosby said. I'm the first person, I think, in this role in terms of having someone focused on behavioral science within PEPFAR, although there certainly have been many people within the US government who do this work. And of course, many of us in academia think about this and work on this as well. So if you can advance the next slide, that would be great. Just a little bit of framing. So when Mike and I came in, I was so pleased to see that in the 5-year strategy that was just developed before we arrived, there was already a recognition that using behavioral science or applying a behavioral lens to the work we do is critical. And as it says here, that recognizing human behavior is essential to all aspects of programs, and that we need a greater focus on this, on individual, social, and structural influences on health behavior. And I think Mike articulated this so nicely that often we're thinking a lot about the individual. How do they interpret and navigate the healthcare system? And as a physician myself, you know, I sit within the healthcare system, but I'm also sometimes a patient. And those experiences can be very different, even for someone who's quite familiar with the healthcare system, yet alone someone who may feel stigmatized or discriminated against. And so these are things that we have to keep front and center, because our goal right now is to accelerate in terms of closing those gaps and sustaining this response, no matter where we head as we go forward. Next slide, please. So this is a phrase that many of us have said after the ambassador articulated this so beautifully, which is what has got us to here won't get us to there. It's a simple way of thinking about where we are right now in the global epidemic of HIV. And you can see from this slide how critically important PEPFAR, along with other partners in this space, has been to closing gaps in care. And you can see this has really been something that many people didn't see as achievable. When I was a resident, I spent a month at the World Health Organization when Jim Kim was there. And I remember he had this statement he wanted to do the 3x5. And that seemed impossible to get 3 million people on treatment by 2005. And we can see from the data that Mike presented that we have far superseded that, and yet there's still more to do, right? So we've gotten here, which is tremendous, and we have to acknowledge that. And Dr. Goosby really was the leader in creating this runway, creating this space, forming these critical partnerships to stand up an incredibly complex program. And now we have to be thinking about what are our strategic steps going forward. Next slide, please. So there are many opportunities to think about how we can synergize science along with programming. And I think that that's really exciting. It's certainly something that people have been doing, although perhaps now there's even more room in a more formalized way to be thinking about this. PEPFAR puts out many different types of documents that they share with all of their partners across the whole portfolio of countries, and they are known as technical considerations. Those are kind of the main ones that are kind of the meat or the nuts and bolts of how we share knowledge around the technical aspects of our work. And more, we're really trying to ensure that the way we share knowledge has this integrated space of communicating with science, such that the science is feeding the programmatic work and the programmatic work is feeding back to the science. Next slide. So in the most recent technical considerations, we actually were able to add an additional note about the importance of behavioral science. And again, highlighting what is being echoed far and wide across the World Health Assembly. There was urging the use of behavioral science to really develop and strengthen effective, tailored, equitable, and human-centered health-related policies and functions. And again, I think PEPFAR is so unique in the way it straddles many different worlds, including discussions at the policy level, which directly impacts behavior. And we know from many policies that have changed over the last few years, this is needed now more than ever. It also says here, PEPFAR operating units, which is really a term used for countries, are urged to employ evidence-based approaches based on behavioral science that are cost-efficient, scalable, and tailored to local needs to address these critical barriers, like service uptake, medication adherence, and stigma reduction. So I think this is often where the challenge lies, to ensure that that science is translatable at scale. And I think for many of us, including myself, who have worked hard in research, that's often the biggest and most vexing challenge, is how is this going to translate to something scalable? And yet there's such a tremendous need for this data to inform what we're doing. Next slide, please. So we are at PEPFAR recreating a hub of knowledge. Right now it's called PEPFAR Solutions, and it's going to become something known as the Knowledge Hub. This is a platform right now. It hasn't been stood up yet, so stay tuned. But this is a place where we will be sharing knowledge on some of the most important and relevant and scalable evidence-based strategies to address some of those problems and challenges that Mike has articulated. And again, we see this as an opportunity to have a very living exchange of knowledge, that we want countries and people who are doing this programmatic work to be sharing back information real time, the same way we'll be sharing information from academic researchers like many of you, to ensure that there's this constant dialogue and engagement. Next slide. And while I do think behavioral science really anchors within the idea of acceleration, there is an important role to think about in terms of sustainability as well. And we can think about this within the context of a larger body of work that's happening right now, and Mike's very involved in this as well, around developing country-led sustainability roadmaps. And I think this has been something that's been discussed for a while. I know that Dr. Goosby actually had this front and center in many ways, even in the earlier days of PEPFAR, is how do we ensure sustainability? How do we ensure a sustainable program and solution that is driven by countries? And so in the context of behavioral science, we can think about how we are integrating people front and center to whatever response we're giving, and building in the capacity within healthcare systems and communities writ large to really ensure sustainability. So again, lots of opportunities here. We see this rooted within community work, and there's certainly partnerships across communities that have already been stood up to support long-term sustainable solutions. Next slide, please. And so again, I think the goal here is to use the data that we have. We collect a lot of data at PEPFAR. That is something that PEPFAR takes very seriously. There's also a lot of data that you all, as researchers or people who are involved in the research enterprise, collect. And of course, there are lots of different cross-cutting collaborative endeavors and networks. So ideally, all of these data are speaking with one another so that we can inform where we need to go. And if we are sure and clear of our direction, then we will have the best opportunity to respond in a meaningful way. And so a lot of this work right now, when we're thinking about the positionality of this, we're thinking about how do we both ensure that we understand where our biggest gaps are, where our biggest challenges are, where we can then bring evidence-based interventions to bear, where we can think about that implementation aspect and the scale. And then again, I think one of the things that I think about a lot is how do we then measure the impact of anything that we're doing? And again, I think part of what we're trying to be careful about is not overburdening programs and countries with more measures, but using measures that are driven by countries themselves, such that we can understand what's working and what's not working real time. And again, I think right now we're thinking ideally we'd have a minimum program requirement that would have basic information that we can really be disseminating for countries to address challenges. But this is going to be very tailored to each country, since there are such differences across all of the countries that we serve. Next slide, please. I'll just flag a new activity that was just started right before I arrived, called the Behavior Change Accelerator. And this is a really exciting partnership. It's a public-private partnership to really leverage private sector expertise. And it's resourced across, as it says here, 4 of the largest, most impactful donors in public health and a select group of private sector partners. And the goal here is really to catalyze and scale a lot of the behavior change strategies that we see helping address some of these challenges. These are completely country driven. So we have disseminated the word. Countries are coming to us and saying, look, we have this space. We'd really like to focus on a social networks intervention for young people. And we bring in private sector partners who have a lot of resources to bear and maybe have some expertise in this. And we can partner them up with countries who are interested in working with them. So we've had a lot of interest in this. I would say everywhere I go, there is a lot of excitement about the BCA. And so we're really excited to help propel this forward and be thinking about ways to leverage this catalytic partnership. Next slide. And then part of our activities, of course, is to develop a compendium of these evidence-based interventions. And again, using that as a piece of the synergy here that we're talking about, whether we are bringing in private sector expertise, whether we're bringing it into program implementation, or utilizing it in other ways that are most catalytic for our partners in country. And again, I can't stress enough, if these are going to be local solutions, we have to be empowering our local partners to be able to drive towards this. Next slide. So again, this is just a different visual to be thinking about, how do we really develop a strong foundation in sustaining behavioral interventions? Mike and I know many of you, believe fundamentally in the importance of building capacity. While there's been a lot of work in this space, actually through PEPFAR, and we saw the incredible evidence of that during the COVID pandemic, there's a lot more that we can be doing here, particularly in behavioral science. We think this is really a great space to be ensuring that we support and develop capacity in country. So that is an anchor within the sustainability aspect of this work. Of course, this also means that we have to have knowledge translation, and we have to develop a behavioral science culture that is engaged in this as much as they are in many other aspects that we're doing across the PEPFAR platform. Next slide. So I'll just close with a few more slides about person-centered care. And again, I just really use the ambassador's words. He has clearly articulated that person-centered care is a core principle of PEPFAR, and that it puts, again, people in communities, not diseases, at the center of health systems. Now, one could say that's a bit of an interesting challenge in the context of a program that is primarily focused on HIV. But we think about this really from kind of the inside out, that people come first, and that yes, HIV is a critical piece of our mission. It's the main piece of our mission, and that is what we are funded to be able to do, but that we think about the person holistically to ensure that they can take charge, as it's saying here, of their own health, rather than being passive recipients of care. And that looks like many different things in many different places. Next slide, please. So these are some of the core principles. I'm sure most of you are very familiar with person-centered care, so I don't need to go into any great detail here, but I always like to anchor this discussion in some of what we believe are the core principles, obviously embodying respect and empathy and honesty, talking about that client-patient relationship, and how do we ensure that there's trust there. I think trust is absolutely critical to any relationship, and particularly one where your life is really in the hands of others. I think really centering the patient perspective is a critical piece of this, and then that larger biopsychosocial approach that's much more comprehensive than maybe has been utilized at other moments. Next slide. So these are some of the challenges that we all know. When we can say this, I mean, it says here in LMICs, but we know that this is true in the United States as well. So I feel like I should just call this a challenges slide. Lots and lots of aspects here we can see in our own care. And if there are other physicians in the room or medical students or people who are training, these are things that I always try to hold front and center. And I feel so lucky I went to medical school at UCSF, because this was something that was really heavily emphasized in terms of my training when I was in medical school, about how we ensure that we don't fall into any of these traps, and that we really think about the larger sociocultural factors that are impacting people's decision-making in terms of their choices for their healthcare. And so we have to be keeping this front and center, and that's part of what we want to do with this program. Next slide. And so I think I just have maybe 2 more slides left before I pass it back to Mike, but wanted to just share a few scientific advances. And again, since I can't see you all, I don't know who is present, but I know that UCSF anchors a lot of the work that has been funded through PEPFAR, that's led in terms of the science that we think about at PEPFAR. And so For those of you who maybe are earlier in your careers, you are getting to work with some of the best and brightest. And a lot of this work is highlighted in terms of the scientific advances that we see here. Again, some of these include in Kenya and Uganda, a dynamic HIV biomedical prevention model that achieved higher retention than previous high-risk subgroup studies. In Eswatini in South Africa, integrated response of HIV and non-communicable diseases through a decentralized drug distribution, reduced wait times and missed appointments. And Uganda, they've modeled clients using preferred care models to achieve higher viral load suppression, and they were way less likely to miss appointments. Again, I think a lot of this is intuitive for many of us, but a lot of times when you see these data, it just makes it that much more compelling, particularly for governments to be thinking about whether or not they want to invest the resources to adopt this. So I'll just have one more slide and then I'll pass it back to Mike. Just to say there are many opportunities here, which I'm so excited about. Community-led monitoring is really an area of great importance. This is something that definitely varies from country to country in terms of the investment and engagement, but it's something that we are really hoping to continue to support. Community-led monitoring is essentially having community members be in charge of sharing out and monitoring how care is provided. And they are a critical force to providing information. Certainly scaling multi-month dispensing. This one is being done in many places, including up to 6 months of medication dispensing. But many countries still face drug shortages or other barriers that they need to overcome in order to provide this. But we know from data that this is a very effective way to provide medication to people living with HIV. Certainly integration of services, TB, mental health is an area that also sits in my portfolio. It's something that we are really focusing on now. Of course, a lot of the other factors that Mike talked about, chronic disease, combination prevention, the HIV choice agenda, which is mostly around prevention, and drug pickup locations like Amazon type lockboxes in many places. The potential for population and person-centered prevention and treatment remains so large. And so opportunities that can decentralize care and provide household-based services always makes things easier. So models through differentiated service delivery and using that human-centered design can really help inform a lot of these models. So I'm very excited about this chapter. I'm going to turn it back to Mike for the final few words and slides here, and then we can open it up.
Thanks, Ingrid. Yeah, I just have a couple more slides, and I just thought it'd be interesting to look into the future with you all, and think about some of PEPFAR's priorities moving forward, and then we'll give ample time for questions. But one thing that we've both alluded to, but is a key priority, is working closely with UNAIDS to facilitate a sustainability agenda in each country that we're working in service of developing a roadmap towards country ownership of their HIV programs. There's recognition that moving forward, many countries can and should assume greater ownership, both political, financial, and programmatic ownership of their HIV programs. And at PEPFAR, we're really committed to facilitating that process. And that means thinking about creating an enabling environment for people living with HIV, where there are laws and policies in place that ensure equitable access to healthcare. It means thinking about enabling domestic resources to be mobilized in support of health programs that include HIV as part of their essential package. It means creating that infrastructure so that countries can do and deploy science rapidly as science evolves to respond to the HIV epidemic. And it involves using the country's own healthcare system rather than vertical programs that may have been established. This is all well and good in theory, but the reality is that there is actually a limited evidence base to support this. There's some great science out there, just recent science looking at how to integrate HIV care into primary care infrastructure in Uganda and Kenya. Sorry, Uganda and Tanzania. In the Inter-Africa study, I've included the inset here from a paper that was published late last year in the Lancet. But nonetheless, that study raised really important questions. Can and should very successful, effective vertical programs be integrated into health systems that are weak and fragile, and what are the strategic investments now that can ensure that those healthcare systems are robust enough to support HIV programs if countries choose to integrate their HIV programs into their primary healthcare systems. Another key challenge related to sustainability is ensuring that equity is prioritized, particularly for key populations. As I mentioned earlier, when we look across our programs, PEPFAR has done a really good job of advancing equity across many dimensions. But for key populations, there's a concern that greater country ownership may undermine access to services if those countries' governments do not facilitate a legislative or human rights agenda that makes it safe for those populations to access services. And so how do we facilitate greater country ownership whilst also prioritizing healthcare for key populations? And then another key question that we're really focused on, and this is part of the new Bureau's greater mandate, is how can we leverage the investments of PEPFAR to enhance health security more generally, build resilience in service of that? These are all important questions that we're asking. And I just wanted to end where I started by highlighting a paper that actually Eric wrote. I think it was published in 2023 or 2012. So 11 years ago, outlining a vision for greater country ownership, new paradigms for global health that would realize that the opportunity of taking the vertical investments and integrating them into primary healthcare systems, enabling greater country ownership and a shared responsibility for the HIV epidemic. And I think, again, I want to end where I started, which is just lauding Eric for his really prescient leadership. I think many people feel he was before his time at PEPFAR, given that we're now circling back a decade later to things that he had been advocating for during his tenure. And I express my deep gratitude to Eric for his leadership in that sense. But I think both Ingrid and I will wrap up now. Eric, we'll hand back to you in the room. We're happy to answer questions or have you add any additional reflections. Thanks, everyone.
Well, great. Thank you, Mike and Ingrid. Really a remarkable reflection of a lot of preparation and thought went into this, and thank you for sharing that with us. It stimulated a lot of thinking in me. I'll turn to the group. Are there any urgent questions that people want to throw out, or I'll start it off? I guess thank you again for that really breathtaking data distribution display of things that are remarkably difficult to create. I know you both know that, but it is so gratifying to see that it's still going on in a way that is unique. The sadness is the uniqueness of it. And I worry, as we now have challenges around funding, resources showing its head once again, and thinking about how we can hold our in-country leadership accountable for the services that their populations need, that PEPFAR has been investing in. Now a paradigm shift, asking them to reconsider the priority that they put toward their global health delivery systems in general, which are their primary care delivery systems. And I'm curious how you're thinking about that, especially in the behavioral aspects. Ingrid, you can start, and then Mike.
Okay, I was going to say, Mike, you can start first.
Okay.
Yeah, I mean, I think that, thank you for that question. I mean, this is front and center for us probably on a daily basis. We're talking about the larger ecosystem that we're living in and the need to ensure that we are supporting countries to lean into this moment. I think we have, as you have said, a unique moment right now as we are, we maintain our funding, which is wonderful. And fortunately, we've always had, PEPFAR has always had bipartisan support, largely because I think it has had such impact and continues to. And we have to be thinking really about that integrated care and how do we ensure, and I think there was a question in the Q&A about a lot of these other care needs that people have, from mental health to non-communicable diseases, tuberculosis. And so we actually feel like this is a unique moment that may not be with us forever. And that is why we have to remain deeply connected to countries to support them in their leadership as they are leaning into this space to ensure that they have the care and long-term sustainability for the people who are living there. And I will say that we also have an exciting moment to also be thinking in partnership with other investments that the US government is making. It always has been this way, but I'll just say as an example, one of my dear friends, David Walton, took over to run the President's Malaria Initiative. And we both work very closely in Cameroon. And we were just discussing the fact that this is a really exciting time to think about how do we leverage these dual investments in this space. And this is true in many other areas, to actually be channeling resources in a accelerated way. So I think there's lots of ways that we can be thinking about this, but it is probably in many ways, as Mike articulated, some of our bigger vexing challenges in terms of integration. Mike, I don't know if you want to speak to that more.
I'll just say two quick reflections. I mean, I think we're using this term integration. I think particularly in a political landscape, it often gets conflated or misconstrued as relating to family planning and abortion services, and certainly on the Hill, that's what people worry about when we talk about integration. We're really not talking about that. We're talking about how we can use our investments in HIV programs to strengthen health systems at large, particularly if that is the country's desire. And I think that's what we're seeing in many countries now, is this a country-led movement towards transitioning HIV programs into primary care infrastructure. And I think a question for PEPFAR is how can we ensure that the quality of the HIV program and the outcomes are maintained if countries choose to do that, which will require a teleological shift in how we think about what we're doing, so that we're supporting countries to do that. But your question, I think, Eric, was also about like how do we motivate or facilitate countries to take on greater ownership of this. My sense, and Eric, I think you know this better than we do, is that many countries really do desire to run and own and fund their own HIV programs. That is their kind of end goal. And so how can we use our investments to facilitate that? There's a lot of thinking right now around, are there specific strategic investments that will help countries towards that goal? Some of the things we're thinking about are the expanded role for government to government funding rather than through implementing partners. Some people are thinking about using co-financing mechanisms, which isn't something that PEPFAR or US government has done before, but many other donor agencies do to motivate more investment from countries into their health systems. So that's kind of just at a very high level. The other thing I'd say is that I think we're trying to take an all of domestic market approach to health services. So how can we leverage the private sector where they're delivering care to also be part of the market that delivers HIV services for those members of the population that are able to access private healthcare, so that those individuals aren't necessarily being covered by PEPFAR dollars. So that's a kind of a very high level summary.
Thanks for both of those answers. Are there any questions in the group? Yes, Payam. I can people hear you? Oh, great.
Oh, okay. Yeah.
Okay.
Hi, Dr. Katz, and hi, Mike, Dr. Reid. This is Payam Nahid. I'm happy to have joined IGHS as the new executive director here. Really enjoyed your talks. My question to you is, I thought you had really incredible thought-provoking comments. The type 1 challenges you delineated, Mike, really are important to tackle. The BCA, the accelerator program, is truly exciting. My broad question to you is, what role do you see from your position at PEPFAR? What role do you see for academia in facilitating those programs and addressing those challenges going forward the next 10 years?
Yeah, I have an answer, and maybe Ingrid does as well. I mean, I think there are key questions, and I highlighted some of them where we do need robust science to inform where we're going. I think the way that we do science in PEPFAR programs has to be informed by the expertise of scientists in academia. I think where I would like to kind of shift the paradigm around research within PEPFAR's programs, though, is can we do things faster? And I think this is what the kind of the challenge that I faced since I moved to DC is we want to do science, but we want to do it faster than NIH does it. So I think one thing I'm really thinking about is, are there implementation science methodologies and approaches that will allow us to deploy rigorous science, but do it on a timeline that it allows us to inform strategic goals for programs. And then there are like specific areas where we're always going to need academic partners to help us answer science questions. And I'll just say one last thing and hand over to Ingrid. The other piece where academia plays a key role is capacity building. Eric led the NEPI and MEPI initiatives, 10 years ago, which were all about empowering academic partners in sub-Saharan Africa to build the next, to train the next generation of healthcare workers, to build out the capabilities to provide technical assistance to programs. And I think that's another role where academic partners still can and should support HIV programs. And certainly that's something we're very invested in realizing. Ingrid, anything you want to add?
Yeah, no, I mean, I think Mike has been a real champion of this, particularly these real-time measures when we think about implementation science and hubs that could be anchored within partner countries. And I completely agree. I mean, as somebody who has been fortunate to receive NIH funding myself, I understand the pace is very different from where we need it to be at PEPFAR. And so again, our goal is to really bridge these two worlds, because the rigor that academics bring to this is key. We have to be able to use that level of rigor when we're thinking about things at scale. So this conversation is critical all the time, ongoing ways. And again, for me, I'm also thinking a lot around, how do we measure things differently? Can we be doing things that are different types of measurements that can really inform ourselves strategically as we're going forward? And I think academics often have some of the most innovative and thoughtful ways to be thinking about measurements. And so again, these are tools and strategies that we're eager to continue to engage in, champion, support as we go forward.
Thank you. Yes.
Hi, Ingrid.
Good.
Hi, Ingrid and Mike. Thanks for a great talk. I know both of you, but Michelle Shang from the Malaria Elimination Initiative here at UCSF in IGHS. I had two questions that are kind of related to elimination. One challenge we have in malaria is that as malaria transmission comes under control and you're moving toward elimination, all the partners sort of lose interest, and the government as well. And so it's just really hard to sustain the activities, and then malaria resurges. So what have you done? How has that been addressed in the HIV world? And then separately, and it may happen slower because it's a chronic disease, but there are incident cases. And then on the elimination front, what's going on with the status of HIV elimination efforts? I know there was a lot of interest in eliminating mother to child transmission, and then also talk of eliminating transmission completely. What's the status, and what's PMI's goals in that area? sorry, not PMI, PEPFAR, sorry. Yeah.
You want to
Do you
take
want
that?
to, do you want to?
I mean, I can, yeah, go ahead, you start. I'm also aware it's
No, go for
4.
it.
I don't know if we, maybe this would be, I don't know if we want to be respectful of people's time, but go ahead.
It's 1-0.
So to your second question first, Michelle, I think we're quite a long ways away from elimination discussions in PEPFAR programs. Even in countries that are at the 395s, there are still ongoing transmission. I think there's hope that making more widely available testing services and then long-acting agents targeted to at-risk communities could really help drive down incident HIV, assuming that we're able to maintain a healthcare system that can maintain very high levels of antiretroviral coverage. I think the future scenario is that we're going to have a sustained investment in HIV programs for the long term, unless there's a cure. And even if there's a cure, I think the infrastructure to deliver a cure and the lab capacity to facilitate the kinds of cures that are being discussed right now is probably still beyond the purview of LMIC. So all of that means that I think there is going to still be a need for sustained investment in HIV programs. I mean, our hope is that in countries like Botswana and Namibia, they will be able to assume more and more of the financing and the oversight for those programs. But countries like Malawi, which have a great HIV program, will never be able to fund those programs and are going to continue to need sustained investment from donors. Now, whether those donors are funding local implementing partners or governments, I think that those models for how the services are dispersed will warrant further scrutiny. But I think a key message is that PEPFAR shouldn't, and I don't think will be going away anytime soon. I don't think either side of the Congress would want that. So that's a sort of answer to half your question. I'll let Ingrid answer the other half.
Yeah,
that was
no,
a
I
great
mean,
question.
yeah.
So go ahead, Ingrid.
No, I would just say I'm in complete agreement that we're not going anywhere. I don't think PEPFAR is leaving. And I don't think the US government investing in these programs is going away. I think we talk about epidemic control, but obviously in countries like South Africa, which is where I predominantly have worked, the numbers are just too large when you get to the 95s. If you reach those 395s, you still have over 1 million people living with HIV who are not virally suppressed. That means you're not going to reach epidemic control with those numbers. And so we have to be thinking in a really engaged and thoughtful way. And each country, each region within each country has its own unique strengths in many of the aspects and also its unique challenges. So I'm just in full agreement with Mike that this is a long-term investment. I don't think we can think about this as just kind of, goodbye. And malaria, I think, is a different type of example, but I think in a way would benefit from long-term support from the US government to really be able to do similar work. I'll say that. Thank you.
I want to just thank you so much for the honest discussions that you've put forward here. The one thing I wanted to do before I left is Ingrid reminded me of, this could be, as we moved more towards the security part of the equation, especially in the Bureau, a reflection of that pivot away from programmatic support that PEPFAR represents to more of the long-term investments in countries' delivery systems that are related to pandemic threats. Pivoting to being that in the Bureau of supporting more of the primary care platform type agenda because of the non-specificity of it to one disease, you start to look at a platform support. And I think talking and convening UNITAID, UNAIDS, and Global Fund, especially the two of you big motors, to think about, is this a time to think differently about what we are to in-country partners and how we do our work? And are there pieces that can be given to the other entities that isn't appropriate for PEPFAR? Now might be a time to really think through that.
Yeah.
That they could do,
We're in complete agreement.
Yeah.
Thank you.
Well, really, thank you so much. And it was just wonderful to see both of you. And if we can give them, thank you for the effort they put through. A rousing crowd. Thanks again.
Thank you, guys.
So
Take
much.
care.
Take care. Bye.